Recently, I had the high honor of going to Dublin, Ireland, and hanging out with Cian McDermott, among others, at the VTE conference there in Dublin, Ireland. Such a fantastic experience. In between the busy schedule, I was able to sit down with Cian McDermott and talk about one of the topics that I talked about there at the conference, as well as something we are both super passionate about, and that is ultrasound-guided nerve blocks. Check out the podcast for our thoughts on the matter. Before we get started with that, I just wanted to let you know that CastleFest 2020 is up and running, or at least the website and the registration are. Go to castlefest2020.com and check out the schedule, check out all the pre-course conferences that we have, and consider coming to hang out with us in Lexington, Kentucky. We're going to have some world-class instructors there, some world-class teaching, hands-on simulation, as well as being able to hang out in the beautiful southern of the United States in Lexington, Kentucky. Check it out. Hello, I'm here with Cian McDermott. Cian, how's it going, man?
Great. Good to be here recording on site.
Yeah, absolutely. I am on location with Cian in Dublin, Ireland. We just ran, actually, we didn't do anything. Cian and his colleague Tomas Breslin ran an amazing ultrasound workshop in the Mater Hospital in Dublin, Ireland. Last time that we chatted, we had this great podcast about, hand positioning and stuff. Yeah. You were in my hometown in Lexington, Kentucky, and now we're here in your hometown of Dublin, Ireland. I know, it's great. Yeah, I'm excited. It's been very welcoming. I'm having a phenomenal time here, and the workshop was great. I mean, we had lecturers from basically all over the world, and then we had a bunch of new learners. We had some people that had never touched a probe, and we had some people that are more super users, but everybody was so enthusiastic about learning this ultrasound stuff.
Yeah, and I think that's the bit that you just get the engagement and the vibrancy in the room, and there's just this surge of positivity, and that's the bit that brings me back to education the whole time, because you can see that spark in people's eyes when you show them some new stuff.
It's reinvigorating.
Yeah. Oh, completely. Every day, every week. I love it.
Yeah.
But I'm a convert. We are.
Right.
So, Jacob, you were in Dublin for a couple of years ago for a smack when you were here with your wife, Shanna, who's probably going to bring us coffee shortly.
Yeah.
It's a bit more of a relaxing time for you now. What have you been getting up to in Dublin?
We started off on the west coast where the Cliffs of Moher are, and that was just like life-altering. It was just beautiful location. I got to surf in Lahinch.
It's pretty cold out there.
Yeah. I had the 5'4" wetsuit, had the booties. I would have loved to have had the hood, but it was a great experience. I think I've only surfed when it's like storming, like a handful of times, and it was storming while I was there. There was like 4 people in the lineup. It was so much fun.
So you earned your waves.
Yeah, exactly. Yeah, I earned them. Yeah.
And so Dublin's been good to you so far.
Yeah. Dublin's been good. We've done the Book of Kells, which is I'm going to be honest with you. Like when I heard the concept, I was like, I don't know. Like it's just a book. It's fine. But when you see it, it's like, oh my gosh, like there's so much history involved in this.
That book is over 1,000 years old and was buried for nearly 200 years to save from the marauding Vikings that came through. So the monks buried it, and it was unearthed. Well, I don't know when it was actually unearthed. I should know because that's my university. But it is pretty much a national treasure. It's hard to find anywhere. So it's very impressive. Yeah. And they only let you, the guys, the caretakers, turn one page at a time, and it's prescribed. They have to wear these muslin gloves so they don't damage the parchment paper. So it's pretty impressive.
Yeah. And we saw the bog people also.
Oh. Yeah, I think you told me about this over there.
Yeah. So it's the archaeology museum. I forget exactly what it's called.
Oh, the National Museum. Yeah. Opposite government buildings.
Yeah. And then they have all these. There's a lot of bogs, I guess, in this region. Yeah. And there's a lot of like people that were like murdered, basically, like chopped up and then like thrown into these bogs, and we're uncovering them like thousands of years later. One of them has you can see fingerprints on them. Like that's how well they're preserved. Like it's fascinating.
They're preserved in the limestone in the bog, and they're often layers and layers deep underneath. And we cut that stuff. We call it turf. It's like kind of fuel that you can burn during the winter when it gets cold. And that's what happens sometimes. You find all these archaeological digs, and there's a Roman road close to the one that I live to, close to at home. It's
so much history.
It's amazing. Yeah, this country is steeped in history, but lots of countries are. That's just our flavour. So, Jacob, the conference that you came over to help us out with and talk at is themed venous thromboembolic disease, so VTE, and you talked specifically about using POCUS in VTE diagnosis, and you had some really interesting points. I think I've seen some of that talk before, but you talked specifically about upper extremity DVTs and calf clots. Can you tell me a little bit about what you explained just an hour ago?
Yeah, sure. So DVT is something that I think we all are somewhat familiar with. Upper extremity clots are things that usually have a less morbidity and mortality attached to them, but there's still something that we have to have on our radar. Actually, I didn't mention it, but I had maybe 2 months ago, I forgot what the name of it is, but it's like a specific like eponym disease.
Is it Meigs syndrome?
No. It's where they have it's in painters and like baseball players. It's repetitive overhead trauma. Then they'll get a DVT. And it's like Osgood, it's like Schlatter something syndrome. I forgot. I'll put it in the show notes or something like that. But I looked it up after the fact, and the disease is called Paget-Schroeder disease. I hope I'm saying that last part right. In any case, it exists, and we should probably treat those very similar to DVTs. With calf clots, traditionally, calf clots, you think, they're really not that big of a deal, just serial imaging. But it turns out that depending on the patient population, a very high percentage of those might actually propagate and cause PEs, which cause morbidity, cause mortality. And so my practice is, on average, to treat these patients with anticoagulation. And if you really look at the guidelines actually support that, even though if you just look at kind of the abstract, it seems to imply that they're not that big of a deal. But when you read the fine print, it turns out that most patients with calf clots, we should probably be treating with anticoagulation.
I think a lot more than we previously thought, which is a very interesting point. And when you drill down into the detail of that ACCP paper from 2016, that's what it seems to suggest. It seemed what high-risk clots were kind of not so high risk.
For
the things that we'd be scanning anyway.
Right. It was like positive D-dimer, history of previous DVT. Like it's things that like that
would prompt us to scan.
Of course.
Yeah.
Exactly.
And 2 points we kind of in the discussion session at the workshop yesterday we came across. Well, the first one was whereby it's really useful to do a pre-scan. So you're putting in an IJ, and why not look for thrombus? You're going to be there anyway. Look for the anatomy. Is the vein on top of the artery? And why not look for thrombus there? Because that's going to influence what you're going to do. You're not going to stick a catheter through a thrombosed vein.
Probably a bad idea.
Yeah, not so good. Yeah. Especially when you show that one that was floating and bobbing in the IJ. Yeah. And one of our vascular sonographers pointed out, if you have a clot in one vein, say in the mid-femoral vein, always look on the contralateral side at the SFJ, so the kind of branch points where the traffic is going to be busy, where the blood will get sticky. I thought that was a really nice point. But then what are you going to do? It's an increased clot burden, so it will influence your decision to anticoagulate. So two really nice, useful practice points. And you also brought up a point about right heart strain in cardiac arrest.
Oh my goodness, this is crazy.
And a lot of us, well, what I've been doing is, you do your kind of CASA protocol, you look at the heart during your CPR pauses and see what the heart is doing. Is there any sign of right heart strain? But you showed a video that showed some significant right heart strain. You made a very important point about that in cardiac arrest.
Yeah, so if you have a patient that is sick, they're short of breath, they have chest pain or whatever, and you see this right heart enlargement, especially if you have a patient that has like McConnell sign, they have no other reason to have right heart enlargement, I'm pretty comfortable saying that patient has a PE as the cause of the right heart strain, right? The problem is that we have extrapolated that to arresting patients, and the data with that actually isn't all that great, which is kind of crazy. There was a pig study that was done, and I know that I'm not a veterinarian, I don't always see pigs, but it's a good point. So 24 pigs, 8 of which got arrested via PE, 8 of which got arrested via hypoxia, and 8 of which was a primary arrhythmia, and the right heart enlarged in all 3 cases of arrest.
So all the cases of arrest had right heart enlargement?
All of them. So, the most common causes of arrest, statistically speaking for humans, is arrhythmia and hypoxia. Yeah. And both of those in these animal studies created right heart enlargement, which kind of makes sense. If the blood isn't going through the left heart, it's going to back up into the less muscular right heart.
Capacitance system, yeah.
Exactly. And it's going to dilate, right? Yeah. So if you see right heart enlargement in an arresting patient, that doesn't mean that the patient has a PE, which is paradigm shifting for me.
Because a lot of us to date would have seen that right heart dilation and been kind of heavily influenced to push lytics. And it sounds like we've been overdoing that. Even all that said, I know it is an animal study, but it has to extrapolate to humans as well.
Yeah. The physiology behind how that would happen makes perfect sense.
Yeah. So maybe the message is push lytics with much more caution in a cardiac arrest, although at that stage you're kind of down the end of the treatment.
Patient's already dead.
Yeah, absolutely. So but it's important to think about.
The thing that would help, though, kind of push me over, just kind of practically speaking, is if the patient's arresting, I see some what I think is right heart enlargement due to possibly a PE, I'm looking for the DVT. So if I have a patient in whom I suspect they have a PE as their cause of arrest, and you see a DVT, that's a very high positive likelihood ratio for that PE. So, and it's easy to do. Everybody's all up in the chest doing their compressions, maybe doing lines, all that kind of stuff. Nobody's doing anything in the legs. And so I just look down there, and if I see a DVT down there, I'm still comfortable pushing lytics. But if I don't see it, I'm much less comfortable pushing lytics.
Yeah, it makes so much more sense from a logistical point of view, and then the statistics back it up. And I really liked your use of, and I think that's something that's come out in the literature more so in recent years, is the use of likelihood ratios and what that means. So a likelihood ratio of greater than 10 is a test we can use something to rule in.
Correct.
Yes, positive likelihood ratio greater than 10. And then a negative likelihood ratio less than 0.01 is really useful to rule something out. So that's
quick correction there. It's actually 0.1. A negative likelihood ratio less than 0.1 is useful.
So look for the DVT in the distal extremities and then maybe push lytics, or be more inclined to do that.
Exactly right.
Yeah, good point. Well, actually, we've been talking about VTE because that's the theme of the conference that we're here to...
Sure. It's called the VTE conference.
But we had a different idea about what we would actually talk about on this podcast, and we were here to talk about blocks.
Oh, I love blocks.
Nerve blocks. And I've given a talk recently, and I like the title, Blocks Are Not Just for Breaks. And I think
it's true.
As emergency docs, we kind of have to have a tool belt of a bunch of blocks that we can use on a regular basis. And that's what we were going to talk about on this podcast, a group of blocks that we can use, starting from head to toe, maybe as a way to go through it.
Yeah.
What do you think about using planar blocks with ultrasound? Because traditionally the regional anesthesia guys, they would do these things blind, whereas not anymore.
Right. Yeah, I think that this is a topic and a technique that will vastly help basically every aspect. So it helps with patient satisfaction, with patient pain, with functional outcomes down the road. There's actually been studies that show that the earlier we get these nerve blocks in, the better people do in their recovery overall. And then you're less likely to have to need to use stronger medications that affect the whole body, like opiates, right? There's a bunch of different blocks you can do. Before we talk about them, I do have to say there's a couple of kind of caveats. When you understand this and you have good technique, it's very difficult to mess them up. But if you don't have good technique, you can cause harm, like bad harm, if you're not doing it right. So I wouldn't do your first brachial or first superficial cervical plexus block. Not even that. The first supraclavicular brachial plexus block.
Yeah.
I wouldn't do that on a 350-pound man that you have to use a curvilinear transducer with and use a 3-inch needle, right? I wouldn't do that in the first one. The first block that you should do is in a young patient that has maybe a boxer's fracture. You need to reduce it, do that ulnar nerve block, you know? So make sure that you're comfortable with the technique before you do it in a dangerous area like in the central area, but, you know, in the neck and the torso. But once you have the technique down, you should be trying to do this on like all of your patients because it's that helpful.
And I absolutely agree with everything that you're saying. And when I'm teaching this, I've broken it into a 2-step process. So I teach needle guidance first, and I've used a piece of extra firm tofu with little wooden dowels embedded in it so that you can practice your needle guidance, get your green needle.
So you just touch it?
Touch it. So
with the needle?
It's Jen Cotton's idea.
Of course. Classic Jen Cotton.
Absolutely.
Coming up with like practical ways to teach.
And she calls it a tactile tofu task trainer. And each of those words is important because it's tactile. You hit the end point, you hit the little piece of wood or the paper clip that you can bury at different heights or depths in the piece of tofu. And it needs to be extra firm tofu as well. Extra firm tofu looks a lot like human tissue and muscle, carries a little bit of water in it, and you just get that tactile feedback. So people, rather than seeing it, they see it and hit it. And I think after you've done your needle guidance on that, then you're probably ready to move into a simulated situation, maybe some human tissue where you can practice a block. So use a simulator to get your needle guidance technique and to line everything up so everything is in the correct line of sight and you've locked down your arm position and the machine is in the correct position as well. I think that's important.
Agreed. Yeah, a lot of nuances there for sure.
Yeah.
So let's start going, kind of head to toe with the more important ones or the ones that are used more commonly. The brachial plexus. This can actually, it can be a little bit intimidating to think that you're blocking the brachial plexus. Again, good technique. You are very low likelihood of messing this up, right? The one that I use the most, there's basically 4-ish. There is the interscaling block, which is a bit higher. You have the supraclavicular, infraclavicular, then axillary. There's a new one that I haven't tried yet that terrifies me, but I really want to try the Raptor. I really want to try the Raptor. It's I forget what it all stands for. It's like retroclavicular something or other.
Well, the thing that terrifies me about that is
you don't see the needle.
The needle disappears for about an inch of your trajectory, so that terrifies me.
Yeah, I talked to Rune about it, and he's like, the lung is nowhere near there. It all makes sense, and I'm sure once I get a couple under my belt, I'll be a huge fan. But it seems cool. It seems great. The one that I use the most is the interscaling block. And the reason I use that the most is because we have a fair bit of shoulder dislocations that happen in the emergency department. And really, out of all the blocks, that one is probably the least likely to cause complications because if you get that anesthetic, that needle tip, that anesthetic right in that interscaling groove, you don't necessarily have to be right up against the brachial plexus itself. You can actually help hydrodissect and move the brachial plexus away from your needle tip by injecting that anesthetic in the interscaling groove.
And the nice thing with that as well, if you're using it for shoulder dislocation, you're really only looking at the top two roots, so C5 and C6. You don't need to go underneath 5, 6. You don't need to infiltrate the whole thing, which is quite different. I think that's one of the differences when we use it in the emergency room, rather than the surgeons who are looking for total motor and sensory paresthesia. So we can use it in a kind of a point of care regional anesthesia block, which I suppose that's what we're talking about at the end of the day. But a thing that terrifies me about that block is maybe not the block itself, but the fact that my partner is a brachial plexus surgeon. And anytime I mention this, she says to me, you know, there's a lot in the brachial plexus. I fix a lot of these brachial plexus. Make sure you know the anatomy. And I think that's one thing we have to be very clear on, is to understand the landmark anatomy and the sonographic anatomy, to find that interscalene groove between the anterior and middle scalene muscles before we put a needle into it. Because there's lots in the path that we could hit along the way.
Absolutely right.
But a very useful block.
Yeah, no, it's good. And one of the reasons why I like this so much is because not only, if you do it, you know, correctly and put enough anesthetic in there, not only does it sensory block, but it also motor blocks, which makes the reduction itself so easy. One of the stories I like to say, it happened. We had a patient, a young person, a male, who had a shoulder dislocation. It was like the third time he'd had it done, and we went ahead and blocked him, and I had him in the hallway, which is not ideal to do a block in the hallway at all, because someone else might bump you, you know, but it was the only bed available. I had it in the hallway. I stepped away to chart on another patient, let the anesthetic kind of kick in. A nurse came by, a female nurse, kind of walked by, and the patient flexed, he had his shirt off, so he wanted to show his muscles, and popped it back in himself. Just because his muscle was so relaxed that all he did was like just tense up, and it popped right back in all on its own. Like that's how good the motor blockade can be as well.
I didn't realize it was quite that good. So it's almost like, you know, you're using a regional technique under ultrasound to do that Cunningham's procedure.
Yeah, exactly right. The only downside is, you know how when you relocate like a hip or a shoulder under, you know, conscious sedation, you hear a thunk. You don't get a thunk.
No.
Because everything's so relaxed. That's the only downside. You don't get that satisfying thunk.
But on the other side, you know, you don't have a patient that has to reemerge from propofol or ketamine, and you know, you don't potentially have a 2-hour wait for that person to be discharged. The patient is probably ready to walk out once they've had their shoulder relocated, and they're
absolutely.
And that kind of brings me around to the other side of things. I really love using the curvilinear probe to diagnose the shoulder dislocation in the first place, especially if it's an anterior or posterior dislocation. I've started showing my residents that recently, and it's so much easier to read than a plain film, especially for a posterior dislocation.
Right.
And they can check it just afterwards. Even if they don't use an interscalene block, you know, they can check their reduction, often on a big, well-built,
a fluffy patient, maybe?
A fluffy patient.
Yeah. The only downside, or the only caveat, I guess, is if it's like a first timer and there was significant trauma. You know, you want to make sure that there's no big fracture associated with it, because that changes the disposition. But if I have somebody who's a chronic dislocator, and it doesn't, the likelihood of them having a fracture is pretty low, I usually try to avoid the X-ray altogether.
Yeah. I think the X-ray is for the next treating person that comes along the orthopedic fracture clinic. Yeah. And even if you are going to use if you're not going to use an interscalene technique, or if you're going to put them asleep, you can give them a shot of intra-articular local before they go down for an X-ray. It depends. There's lots of ways you can run this one.
You can do an ultrasound-guided intra-articular injection, which I've done before as well.
Yeah, and they work really, really well.
They do well work.
And you can even aspirate the hematoma before you put the injectase in.
Yeah. Although with those intra-articular blocks, what I typically do is give patients the option, like, hey, I can, exactly word it like this, but I can give you medicine in which you may stop breathing. I can give you an injection into your joint, which will help a little bit with the pain, but your muscles won't be relaxed, so I'd have to tug on you pretty hard. Or I can give you a shot in your neck under ultrasound guidance, and you will have very minimal pain, and you'll be very relaxed, and it'll be very easy for me to put this in. Which one would you like?
I think I'd like the last option.
Yeah, me too. Although, sometimes people say, no, just put it inside the joint, and I say, all right, okay. And I don't mind doing that because it hurts less. It's just you have to tug a little bit harder.
Yeah. And it kind of, the patient choice is what's going to dictate this at the end of the day. And it's really important how you frame that. I often say to people, maybe in 7 out of 10 patients, this will take down your pain, especially for the abdominal wall blocks. This will take down your pain by 50%. So people will choose that as part of a multimodal strategy with, maybe some morphine, maybe some codeine. Depends on different things. But I think it's definitely a useful way to block.
Yeah, you bring up like a really good point too, because like to tell people that the pain's going to go down to 0 is not a good idea, because sometimes it does, and if it does, great job on you. But most of the time, it does bring it down 50% or 70%, which to most patients, that's totally bearable compared to the 100% of pain they had before.
Yeah, absolutely. It's all about how you frame that concept. So if we move on from the interscalene block, There's another really neat one that's in the same area, so a superficial cervical plexus block.
Yeah, that's a good one. It's crazy. It's like one shot, the lateral aspect of this sternocleidomastoid muscle, and you basically block the entire neck, the jaw, the clavicle, and the posterior aspect of the ear, and you just dump a little anesthetic, and it does everything. I have a special place in my heart for bicycle wrecks, like clavicle fractures with bicycle wrecks, and I almost invariably offer that. And there's plenty of situations where like I can basically pinch the fracture after I've done this block, and the patients don't really feel it at all. Like, I can feel you touching it, but it doesn't hurt. Which before they couldn't even they couldn't move their arm. They struggled to breathe. Neck abscesses, central lines. Have you done it a lot for the ear?
I did 2 last week, actually.
Really?
We had a guy that had taken out his earring, and he had a big, nasty abscess in his in the earlobe itself. So, I'd said, why not give this a try?
Of course.
And again, he took down his pain by about 50% because the whole area was inflamed and red. So the local was never going to sit in there in the first instance. So we blocked it at the point of entry, at the posterior border of sternocleidomastoid, where all the nerves just spread out in a cape. And it worked really, really well for him. He let us aspirate and irrigate his ear, so it worked really well.
No, I think that block works phenomenally well. And it's kind of an understated one. One situation that I like to use this probably the most in is in an awake patient that needs a central line.
Yes,
because it blocks it doesn't do necessarily the fascia beneath the actual muscle, but there's less sensory innervation down there. It's mostly a skin thing, right? So if you can just block the skin, it works. You definitely can just like put local where you're planning on injecting. But my thing is, how when you have the central line in there, you put the little clamp, and then you have the little loop to put the second clamp. I always don't numb it where I'm going to do the second sutures, basically. But
because you've done the procedure, you feel slam dunk. This is the last little bit, and that's probably quite painful for someone.
You're sewing their skin. You're sewing something to their skin. And if you did the superficial cervical plexus block, the whole neck is numb, so you don't have to worry about that.
Yeah,
right?
and practice point. If somebody jerks at that point and you pull out your central line, you're left looking very foolish. So consider that block as SCP block if you're putting in an awake central line. Absolutely, and even if your patient's is asleep, they can still jerk around when they have a particularly painful stimulus.
Yeah. Agreed.
Will we move on to some chest wall blocks?
I have been using these so much more lately, and they're so helpful. What's your favorite one? Because there's a couple, right? You got the serratus anterior, you have the erector spinae block. Which ones are you using?
Both of those, really. Although when you talk to the regional guys, they have an alphabet soup of blocks. They've MTP block. They've some paravertebral blocks as well. Yeah. So I try to stick. I'm a straightforward sort of person. I try and stick with the tried and tested, and they work in most situations. So for serratus anterior, for anterior problems, anterior chest wall from the mid-axillary line around to the sternum, and then posterior blocks or posterior injuries, I try and use ESPB, and both are pretty useful. What do you use?
So it depends. I didn't know this. I had a patient, one of the most trickiest patients to manage are the patients with axillary abscesses, right? Because there's no way to numb those locally.
It's pretty painful.
Yeah, and in the past, I don't feel good about it, but I'll give a subdissociative dose of ketamine or a full sedation because it's painful and I feel bad for them, patients. And I'm not the kind of person I'm like, you're just going to have to deal with this and let's just get it done. Because I've been a patient plenty of times and I've been in pain plenty of times, and I do not like pain. I'm not a fan of pain, and I don't want my patients to have to deal with that. And so I was trying to figure out how I could, this last patient that I had, how I could numb her axilla because it was just painful. And she was patients that maybe don't have the best coping skills at baseline for dealing with stress. They tend to react a lot more enthusiastically to any kind of painful stimulus, right? So just me looking at it, she was anxious already. So I knew even me injecting in that area would not work. So I remembered that I was listening to a podcast that Matt did a couple of years ago, and he talked about a PEX block. And so I was trying to figure that out. And then I realized doing kind of research, I think I was on the Highland Ultrasound website as well, that you can actually use a serratus block and it does the axilla. And I had no idea that it did the axilla. And I did a block probably posterior axillary line, so maybe a little more posterior than normal. But I blocked it, and within 30 minutes, she needed nothing. absolutely nothing, and I drained an abscess in her armpit, and she was totally fine with it. And it did from the proximal aspect of the upper arm, did all the axilla and did all the side and did some of the anterior chest wall as well. It worked beautifully well for that. I have actually used the posterior, the erector spinae block for rib fractures. It works well for that. So yeah, not just for fractures, right?
Yeah, blocks are not just for breaks. And exactly, I think myself and a colleague used an erector spinae block for a painful shingles rash recently.
Brilliant.
Yeah, so the shingles rash had been there. Guy came in and we thought, let's try a different approach to this. There's no point in just giving regular paracetamol and antiviral medication. So we blocked using an erector spinae block. We're going to do the serratus anterior, but the rash was over the site of the entry point, so we went back around the back. Yeah. And that's another interesting point. Sometimes if you have a trauma patient and you have subcutaneous emphysema, so you're not going to be able to see the serratus planes. That air will disrupt your signal, so maybe you need to go around to the back. I think the ESP block gives you lots of good anterior cover as well. Yeah, especially in a trauma patient.
Agreed. There is, one of the classic situations to use a serratus anterior erector spinae block is for rib fractures. The one thing that I didn't know until recently was that, yes, it does very well for rib fractures. Yes, it is very good anesthesia for the skin and the muscle, but not the pleura. So if you're having to put a chest tube in, that popping, when the patient felt almost no pain and all of a sudden they feel a sharp pain, you got to make sure that you tell them that when this goes through the pleura, it's actually gonna hurt. And there's basically no good way of numbing that with a nerve block, basically.
I found that out about a year ago as well. And again, it's about managing patient expectations. You need to tell them that up front ahead of time.
Yeah.
So for serratus, for the serratus plane block, do you use the deep or superficial approach? What's your thoughts on that?
Yeah. So probably the less risky is to do the anterior approach. So you go superficial, not anterior, superficial. You go superficial to the serratus anterior, because going posterior to it, if the patient jerks or coughs or something like that, and you're not perfectly, like the rib's not right behind where your needle's going to be, you could technically cause a pneumothorax, right? So I try to teach anterior when I'm teaching this, but practically I actually do both. I want to have that serratus muscle completely surrendered from that side. So I dump about half of it deep and half of it superficial to the serratus.
And that's exactly what I do as well. I teach the superficial block, the superficial approach. And then when I'm confident that one of our residents is good at doing that, I'll say, how about for a deeper block, how about try a superficial approach once I know that their needle guidance skills are up to scratch for that block. But it's a really useful concept. And it's a derivation of the PEX 1 or 2 block.
I think it's the 2. I think it's part of the 2. I think. I don't remember. But apparently the anesthetic result is the same, right? Superficial versus deep, apparently. I mean, that's what people tend to tell me.
Well, the original study had n equals 8, and they used 4. I know, great stuff. 4 anterior, 4 superior and 4 deep, and they saw the blue dye move in the same planes in both. But I think a modified approach for that is probably the best way forward, and it comes down to operator comfort at the end of the day.
Of course.
Another interesting thing that I've heard, the phenomenon whereby you have built your patient up and you said this is going to work really well for you, and you put in the needle, you deliver the local, and your patient automatically, as soon as you take the needle out, says, my pain is gone. And that's not possible because
it hasn't had time.
Yeah, because you haven't used lidocaine. You've used we use levobupivacaine. Yeah. Do you use ropivacaine?
We use yes. So it depends. I mean, most of the time I'm using, if it's for a reduction, I'm going to use lidocaine with epi, because that's a 7 cc's per kg maximum dose. So you can put a bunch of it in. It lasts a little bit longer than regular lidocaine. But if it's for which I hope we'll talk about, a fascia iliaca block for a intertrochanteric fracture or a femoral neck fracture, I'm using ropivacaine because it lasts longer.
Absolutely, yeah. So but when you use that long-acting local anesthetic, the patient, you take the needle out, the patient says, the pain is gone, and that's not possible. I've heard the reason for that is because the nerve might be trapped or impinged in that injured space that might be a little bit more swollen than it was. And when you release that, the physical effect of you releasing that space reduces that serratus spasm. So that
interesting.
Yeah,
I have not heard that.
Yeah, I heard that.
I guess that makes sense. I hadn't heard that.
Yeah, and that might explain that concept.
Sure. Yeah.
And then hopefully you get the long-acting local anesthetic effect down the line.
But I wonder if like part of it too is a little bit of the placebo effect too. Like just the fact that you're doing something, their brain is like, okay, you can hurt less now,
rather than a massage.
Right? Yeah, exactly.
Yeah. So Jacob, let's move on to some of the abdominal wall blocks.
Yeah.
I'm growing to love these blocks.
Yeah.
What do you think?
You're talking about like a tap block, right? Like a transversus abdominis plane block. I like them. I think that they're very, very useful. I mean, I've done them when I was learning blocks. I would do them for paracentesis patients mostly to learn the block, and it seemed to do very well. There's good literature out there that actually shows that this can help with post-operative pain, and it can help with diseases that need surgery, like appendicitis, like diverticulitis, even in some studies. So I think it's very useful. Do I use this on a daily basis? No. This is probably one of the less common ones that I use, but I use it because I'm fortunate enough to be at a place where we have really good support from our surgery colleagues. So as soon as I have somebody who's got appendicitis, they're usually getting surgery fairly quickly, and they're getting their pain control via other methods. So I'm personally not using this a lot, but I think it's a very powerful block.
Yeah, I think that's our experience as well. I think our surgeons are on board. They will schedule someone for emergency theatre, hopefully that night if it's a bad case. But sometimes people are in acute pain, and it's nice to offer them the option of, like we say, a block that will reduce their pain as an adjunct to other analgesics. I like it because I love the anatomical muscle layers. They're very clear when you use it, even a regular linear probe. You can see those layers pretty well, and it's very satisfying to get your needle in under the internal oblique and above the TA and just deliver your inject agent there. It seems it's for me it's a satisfying block.
Yeah, agreed. Yeah.
What are your surgeons? Do they find that does it change their physical exam?
So that's an important question, because in the past it's been one of those things where we, for appendicitis, you can diagnose it based off of clinical grounds. So there traditionally has been a little bit of resistance because they want really what it is the surgeons sometimes want to know how bad things hurt in borderline cases. But I don't think that that's a good enough excuse to not give your patient adequate pain control, because most of the time, I mean, if you take your patient to the OR based off of your physical exam, you're going to be wrong at least 20% of the time. So you're taking your patient to the OR using an examination that's wrong 20% of the time at best. So it's not something that should be done anyways. We really should be basing it off of the CT scan, the ultrasound, or the labs. So I guess to answer your question, it doesn't really matter, because if the reason that the surgeons don't want me to do that procedure that decreases the pain is so that they can cause pain in their patients, that's not like a good excuse for me, because I definitely like to be a team player and work within a system, but ultimately my goal is my patients, and that's what really matters the most. And I'm in a position now where I can say that I'm going to do this because it's going to help. Now, caveat, orthopedic injuries, their neurovascular examination is actually very important for what they do to surgery, how they do it, and prognosis. So with orthopedic injuries in which the sensory exam is very important, it's not a pain thing, it's an actual sensory examination. I definitely will basically ask them permission to do the block, because that actually matters more than trying to take patient to the OR based off of pain or not, if that makes sense.
Actively. And when I'm talking to people about blocks, I direct them to a website that's a favorite of ours, Highland Ultrasound.
Yeah, it's a really good website.
Arun Nagdev and Andrew Herring. On that website, down the left, there's a fantastic infographic that shows blocks. It's a green, amber, and red sort of system. So they show blocks that you can do yourself without probably consulting, then blocks that you should have caution before you perform. Like you say, the orthopedic, especially the lower limb blocks that might mask a compartment syndrome, and nobody wants to deal with compartment syndrome, a late presentation of a compartment syndrome. And when you talk to Andrew, they worked on that locally with their orthopedic surgeons and then published about their experiences. And on that basis, they've made recommendations about blocks we should talk to people about.
That's excellent.
Yeah, it's a really, really useful site. Oh, just as a modification to the tap block, I use it a little bit, not a lot, but there is a modification that possibly is more useful than the pure tap itself. It's a quadratus lumborum block, which is more posterior and more medial. So where the 3 abdominal muscles, those linear muscles, the transversus abdominis, external and internal obliques, where they dovetail to form a point, at that point you have the kind of quadrangular QL muscle, and if you deposit local anesthesia there, or local anesthetic at that point, it's thought to work a little bit better.
Interesting.
But the whole thing about a lot of these blocks is that the local anesthetic probably ends up in the paravertebral space and sometimes in the epidural space as well. So I like the dark art that still exists. We don't really know how they work, but I think they're made so much easier when you use ultrasound to perform them.
Definitely, for sure.
So let's move on to the lower limb. So this is our final block, and it's kind of a gateway block that everybody starts with, and it's the fascia iliaca compartment block. And
it's a good one.
Yeah, it's a great one. It's really useful. How many hip fractures would you see, say, probably one a day in our shop?
Yeah, for us, it's much more than that.
Yeah.
Yeah. I mean, I'd say on like a shift, and not a day, on a shift, there's probably 5-ish on a 10-hour shift. I mean, we see this fairly frequently. They don't necessarily primarily come to us first, but all of them get transferred to us.
Yeah,
so we see a bunch of these blocks, and the patient who's going to be getting this femoral neck fracture is generally a kind of deconditioned, slightly advanced age patient. That's usually the person who's getting these, and these are the patients that with pain they're much more likely to have delirium. And with morphine, they're more likely to get delirium, right? So it's kind of like a damned if you do, damned if you don't type of thing with pain control. I've seen these patients turn around so quickly with this fascia iliaca block. I mean, you have patients that basically crying in pain, but their SATs are low, their respiratory rate's low, they're a little bit hypotension because of all the narcotics they've gotten. You just do that block and they can talk, they can breathe, and they don't have as much pain.
Yeah, that patient group is particularly vulnerable to multi-system insult from respiratory disease, from the pain itself, from neurocognitive dysfunction. And there's a lot published to show, again, how if you intervene early, they do so much better, even in the post-operative period. What do you think of it as a block, as a technique itself? What approach do you use?
So I like this block. This is one of the easiest ones to teach the residents to do because you come out, you're in plane. I'm usually doing the infra-inguinal approach, and you identify your neurovascular bundle. And what's cool is that if you find the fascia iliaca, which is right above that neurovascular bundle, you actually don't have to inject next to the nerve. And the nerve is the most lateral structure, and then you have your vessels on the inside of the nerves or medial to the nerves. So your needle is actually pretty far away from any kind of dangerous area. And you got to do a large volume. I usually, depending on how big the patient is, I do either 40 or 60 cc's of fluid. And usually it's about half ropivacaine, half normal saline. And you want to, for me, I like having a large volume because it helps bathe that whole compartment, that whole area. I'm definitely not doing 60 cc's of ropivacaine because that's probably getting up to like a max dose. And I haven't caused LAST yet, or local anesthetic systemic toxicity, and I definitely don't want to have that. So that's why I usually I dilute it. So it ends up, we use our 0.5 ropivacaine or 0.5%, and that ends up being like 0.25% ropivacaine. But there's a kind of a newish technique that I'm really interested in trying out. Have you tried out the suprainguinal approach yet?
I have. I've tried it in a workshop, and I've tried it in our last patient, and Mike Stone showed it to us at Castlefest this year in Kentucky. It seems like a really nice approach because you're much more superficial. So you place your probe at a 12 o'clock, 6 o'clock, so cephalad caudate position, above, just kind of over the iliac crest. And then you fan medially, and you see this beautiful bow tie appear, and one of the edges of the bow tie is the iliacus muscle. So if you inject into the fascial layer, the bright white line, just over that muscle, hey presto, that's the fascia iliaca, and that's your target. So you're nowhere near the nerve.
Yeah.
So it makes perfect sense, and apparently it's meant to give better pain control at an earlier stage. So I'm not sure how that works, but so the suprainguinal approach to fascia iliaca plain block, I think it's nice. And another little tip that I've remembered is traditionally people would go from the fascia lata, look for that fascia lata, then move down to the fascia iliaca. But how about we look for the femoral neck, then look for the iliacus muscle, And then the bright white line that's above that has to be the fascia iliaca.
Oh, brilliant.
So look
That seems
from
easier.
the muscle up and then inject that rather than going all the way down, because there's lots sometimes with patients there can be a lot of subcutaneous tissue. It's just there's more traffic in that area. So look from the muscle up. Yeah, so that's my little tip for that. And the RA guys, the regional anesthesia guys, I would probably end with this kind of quote is they look for quality in the peripheries and quantity in the planes.
Okay. Brilliant. And so quantity meaning large volume,
Yes.
and quality being you don't have to put as much, but make sure that you create a nice little donut around that nerve.
Yeah, absolutely. And I think in point of care, if we can combine both of those approaches and be able to deliver a quality block, but then knowing the benefits of planar blocks, I think planar blocks, especially ultrasound using planar blocks, has kind of democratized who and how can use them. And it's an opportunity to build collaboration within your hospital with your pain guys, with your in-house teams, whether that be surgical or orthopedic. I think the opportunities are there for that.
Brilliant. Yeah, thanks, man. These are all like great tips, and I'm super excited to hopefully get more people to get trained and to be comfortable performing these blocks, because ultimately what we do is about patient care and alleviating patient suffering, and that's why we do these blocks.
Yeah, it's a very powerful thing to be able to do, is to take down somebody's pain in the acute setting, or at least have that trick up your sleeve in the emergency department. So, and we do this with the power of ultrasound.
Yeah, great.
Yeah.
Venous thromboembolism and nerve blocks are not necessarily related topics, but they're things that I am very passionate about. They're things that we, using our bedside ultrasound, I've been able to see drastic differences in disposition and pain when utilizing it. So I think it's important to learn. If you have any questions or comments, please feel free to send me an email or a tweet. Check out a couple of our other podcasts that we're involved with. 5-Minute Sono, some instructional videos to check out. And we also are a part of the Ultrasound Gel, that's gathering evidence from the literature, podcast that Mike Prats runs over at OSU. Make sure to check that out. If you are interested in an online year-long ultrasound fellowship, check out ultrasoundleadershipacademy.com.